Professor Dr. Emel, Ceylan, Gunay from Live Hospital group actually, and she's going to talk about modern method of diagnostic and treatment in nuclear oncology. As you may see that we are concentrating more in oncology because most of our patients and most of our inquiries coming from CIS market, mostly for oncology. That's why we are trying to explore and explain what kind of technology we are using in Turkey to treat our Turkish citizen and international guests and patients. Professor Emel, the floor is yours. Please share your screen first of all,
yes,
and then we give a start. Good. Please go ahead.
yes. Hello, everyone. Thank you. It's an honor to be with you in this virtual environment. I work in nuclear medicine area for more than 20 years, and I work in Live Hospital in Istanbul for 3 years, and I'm the chairperson of Eastern University Nuclear Medicine Department. Today, I want to introduce some of our daily services that we provide to our patients, touch briefly to diagnostic procedures and treatment options, and our different approaches in our departments. In nuclear medicine, radioactivity is used to diagnose and treat the patients. The function of many organs and systems are evaluated. Nuclear medicine department of Live Hospital has become a reference center where we serve more than 300 oncologic patients every year. By the way, I should also emphasize that the COVID-19 risk mitigation is strictly applied in our hospital and our personnel is vaccinated. In nuclear medicine area, for the diagnostic procedures, we use different technical devices providing functional and structural evaluation of the disease. And we have targeted radionuclide treatment options for different disease. In nuclear medicine, functional imaging and diagnostics are strong weapons. And the developments in the nuclear medicine era in the last decades provided astonishing results in oncological care. One of our devices that we mostly used for imaging of oncologic patients is PET-CT. As most of you know, we have started with FDG imaging and continue with newer agents. First, we were using this imaging for staging, recurrence of disease, or early response of the treatments and radiotherapy planning, but thereafter, selection of treatment methods has been added. PET imaging provides more information than other conventional imaging methods. We have started to use more specific PET agents in consequence of the developments in radiopharmacy, which is a very important step for us. The number of agents that we can use increases day by day, and these agents have different distribution in the body. In neuroendocrine tumors, we can show tumoral lesions at the receptor level better than the other techniques, which cannot be detected by other imaging methods. Here, you see a liver. These are the tumoral lesions in the liver, which cannot be seen patients' routine tomographic screening. So we locate the cancer cells, and similarly for prostate cancer, specific imaging is also provided, which is more sensitive than conventional imaging. These techniques provide correct staging and early treatment response and provide additional information for diagnostics. Here is one of our patients who had more than one bony metastasis which is detected by PSMA scanning. The diagnostics, in other words, targeted therapies, these innovative targeted treatment applications provides to deliver higher doses to tumor cells and destruct these cells by irradiating them. These agents irradiate in a short range, so other parts of the body is mostly protected. Our target is the tumor tissue. We don't want to harm to other parts of the body. Here, there are some agents that we use. These are radiopharmaceutical agents in our armamentarium. We can provide different options to different needs. Radioactive iodine in the first line is one of our routines in our clinic, and it's been used for a long time, but we also use other specific treatment agents too. The radioactive iodine was our first targeted therapy, which is used more than 50 years, and it is one of our routine treatments in our department. Here, patient selection is very important in order to minimize the side effects or unexpected events. We review and plan all our procedures together with oncologic units, select the best treatment option for the patient, and criticize our outcomes in our weekly meetings. So that provides us powerful treatment and lower side effects. We follow our patients' outcome with the clinicians closely. One of our targeted treatments is for liver tumors, which we perform together with interventional radiology. Our collaboration and experience is utmost important. And here, think about an agent that you can give directly to the vessels that feed the tumors. And these particles are as tiny as a hair strand. When you combine these tiny particles with radiation, here you cannot see with eyes, very small particles. What happens next is they accumulate on the tumor and acts on the tumor cells. Is that so easy? In fact, it is not, because we do not want to give harm to any other parts of the body. So the planning part is very important. We must be sure that our agents go to the liver, not to the other parts of the body, or to the mostly accumulates in the tumor of the liver. Here I want to share one of our patients' images, which were taken right after the therapy. This is patient's liver tumor, metastatic liver tumor from colon cancer. And here we see the agent that we give to the patient. The agent accumulates right in the tumoral sites. What happened to that patient next is that after 1.5 months, we did a PET-CT scan, and here patient's liver, we do not see any active parts. The patient's liver tumor was suppressed successfully. And here, one of our another patient, this is the patient's PET-CT scan before treatment. Here is his tumor on the liver, and this is the after treatment images after 2 months. Here you see the necrosis. There's no uptake in that part. Another very successful treatment and did not harm any other parts of the liver. Another agent we use for treatment is lutetium and actinium. labeled with PSMA treatment for prostate cancer. These options are generally advised when other treatments are ineffective or cannot be tolerated by the patients. Increases life quality, reduces pain, and there are strong evidences for the survey. These agents are given intravenously. Patients stay in the hospital not more than 1 day. How it acts is these radioactive agents bind to the protein on the tumor cells and starts to destroy them. The mechanism of action is similar, but the pathway differs from agent to agent. This is another agent, radium, which is also called alpha-radin, an alpha agent, which we use for metastatic bone disease, especially for prostate cancer. It accumulates on the metastatic parts of the bone and irradiates those metastatic parts in a short range. Another treatment for neuroendocrine tumors is, we also use lutetium for that. The mechanism of action depends on the receptor level. Our agent attached to the tumor cells via receptors and starts cell damaging. We use a systematic approach, and we are not alone in that side on our way. Diagnostics are modern personalized therapies and targeted therapies of tumor tissues. When we come to our keynotes, continuous scientific developments and investments in up-to-date technological trends and putting patient needs and meeting them to focus every process scientifically would always provide us good results, excellence in oncologic care and in diagnosis and treatment. And I want to thank you for your attention. I'm sure that there are queries because I didn't mention some of the details in my presentation, but if you have any questions, we can continue.
Professor Emel, maybe you can still have 5 minutes more. You can on spot, you can explain some of your experience and share your experience with our doctors who are related to oncology section as well, and they are following your speech now, and they're more interested. They have watched your some of your methods of diagnostic, but you can share some of your experience actually with some patients verbally as well, and you can explain some of examples if you wish.
Okay, maybe I can go on some of the slides and go in detail.
Or some other explanation. Still, we have quite a bit, 10-minute time for question and answer. We can use this time for giving more information and more knowledge to our colleagues who are listening to us. Interesting to listen to Turkish experience and know-how actually.
Okay. I beg your pardon.
No problem. You take your time, please.
Maybe I can give a little detail about our other treatments.
Yes, please.
Here. Yes, first I talked about the radioactive iodine. We use radioactive iodine for thyroid disease. for hyperthyroidism and thyroid cancers, differentiated thyroid cancers. This is one of our routines in our departments. And we have very good results. This treatment options is used for a long time, and also for a long time in our department. We have two treatment rooms, which is just used for our radioactive treatments rooms. And another treatment agent is again radioactive iodine labeled MIBG, which we use for neuroblastomas. We have lots of childhood patients which were unresponsive to therapies after chemotherapies, and we have we see their a good response to that treatments, and they act together with other chemotherapeutic agents, and they give strength to each other, and very well tolerated by our patients. Well, when we come to, I have talked a little bit with lutetium therapy. Maybe I can give a little detail about the actinium. What is the difference between lutetium and actinium? Well, actinium is an alpha agent, and its range is lower than the lutetium. So it acts in a lower range, and the harm to the other parts of the body is very, very low when compared to the other agents. That's one of the new agents. And radium is also an alpha agent. Its range is also lower, and it has been shown that for radium, for prostate cancer, metastatic prostate cancers, it has a very positive effect on surgery and the pain palliation also. But these treatments are preferred. They come after the other treatments when the other treatments are not tolerated by the patients, or they do not work well. But the iodine treatment for thyroid cancers is different. This is if the patient meets the criteria, this is the first preferred treatment, in fact, other than the other options, radiation oncology or chemotherapeutic agents for thyroid cancers. As a conclusion, I can say that we work together with our other oncology departments. We decide together and try to select the best treatment method for the patients. We choose which one is the best and which the patient will take more effect from the treatment options. So we decide together and work together in order to have our achievements for excellence in oncologic care. Thank you for listening.
Thank you very much. We have one question arrive actually, and there is so many interest from CIS countries, from ex-Russian Soviet Union, member countries. Now from Kazakhstan up to Moldova and Lithuania, they are listening to us quite in wide geographical area. We are now talking to about more than 2,000 doctors and professors, and from many universities, professors as well. They are following us from different channels, from YouTube channels and from platform channels, from Facebook and others. There is always this question is coming to us, since oncology is one of the important treatment, especially radio-oncology, important treatment method in the latest technology. They are asking whether they can get some training in your university hospital. As far as I remember, when I talked to coordinator, Mrs. Mary Stority, in my last meetings in Ulus Hospital. She told me about the ex-minister of Kyrgyzstan, I think, has been
Yes.
integrated to Istinia University Hospital, and you create kind of academy for training, doctor trainings. In your section, especially since you are head of the faculty of oncology departments, are you receiving some international doctors to train in your methods or in your technology?
Yes, we receive and we are always open to these organizations. And recently we had an organization for different topics. One of them is about liver treatment options in nuclear medicine. We have also a section in that organization, and we want to increase the number of the education hours, in fact, and by using this environments, it has been easier than past decades. Yes, it's also possible this way.
All right, thank you very much, Professor Emel, and thank you for your contribution and your presentation. Hope to see you in our next virtual online expo as well, because we are willing to continue this events to extend our to share our experience and know-how with all our neighbor countries and cooperate countries like CIS region. Thank you very much.
I thank you so much. It's an honor to be with you.
Thank you.